So it's a great pleasure for me to introduce another one of my colleagues, Dr. Irene Souter, who's the director of the Pre-implantation Genetic Diagnosis Program, you now know what that means, at Mass General Hospital. And I'll just say that one of the things that breaks my heart as an NF clinician is when somebody comes in to see me, they're 30, 40, 50 years old, and they tell me that they were once told they could never have kids because they had NF. And I tell you that really just kills me. And so one of the people who's helped me come to grips with that and really offer more to our patients is Dr. Souter, who's really a world expert. She's going to talk to us today about pregnancy and NF more broadly. And then it sounds like we're going to have the hardest working man in show business join her too. Matt Hay is going to come up and help out. I don't know if you want to do this now or later. Later, okay, so then you'll call him. Okay, great. Thank you.
Good evening, everybody. It is my honor to be here tonight. Thank you for the invitation to speak. As Dr. Plotkin said, the focus of my presentation will mostly be on the topic of pre-implantation genetic diagnosis. You heard a little bit from the genetics counselor, but I will go into more details. So pre-implantation genetic diagnosis is a procedure used by couples that carry a genetic condition that they are concerned that there is a high chance they will pass this condition on to their child, and they want to take some steps to decrease this risk or prevent the passage of the gene to the child. Next slide, please. You can show both, actually. You can click, yeah. So the genetics counselor already discussed with you some of the options of prenatal versus pre-implantation genetic diagnosis. And I just wanted to help you understand the differences between these two procedures. First of all, when couples with NF consider pregnancy, they have a few options available to them. One option is to try to conceive naturally. After all, people that have NF are not infertile. Or, of course, they can let nature, they can hear me? Ah, okay, very good. That's even better, yeah.
And there's a laser at the top.
Oh, thank you very much, okay. So, as I was saying, people that have NF might choose to conceive on their own, do nothing during pregnancy, and await the birth of their child, at which time they can have their child tested and find out whether their child carries NF or not. They have the option of trying to conceive on their own, wait until they're 3 or 4 months pregnant, and then undergo prenatal diagnosis. See, I'm doing something wrong, Scott, okay. So with prenatal diagnosis, they can find in pregnancy whether their baby is affected or not. And it could be that they decide to continue the pregnancy knowing that their child is affected, or it could be that they decide to terminate the pregnancy at that point and try again. A lot of patients, though, might decide that they want to know the status of their embryos prior to establishing a pregnancy. This is where pre-implantation genetic diagnosis comes into the picture. I'm doing something wrong here. Do I have to? Okay.
This one. So this is
the laser pointer?
This is forward, okay. Green, and this is backwards.
Okay, very good.
And this is the laser right there.
Okay, very good. Thank you. Let's try again. So with prenatal diagnosis, the big difference between prenatal diagnosis and pre-implantation genetic diagnosis is that the patient is already pregnant. The patient is 3 or 4 months. So if the patient is undergoing chorionic villus sampling, that's usually done at 3 months of gestation. There is a smaller fetus there. We will remove a small piece of tissue and send this for genetic diagnosis. When people decide to undergo an amnio, they'll be further down the line in pregnancy. There will be 4 months. And at that point, a little bit of fluid is removed from the amniotic sac, and it's sent out for genetic diagnosis. As I said, at that point, the couple has 2 options. They either decide to continue with the affected pregnancy, or they might decide they want to terminate the pregnancy. The big advantage of pre-implantation genetic diagnosis is that it allows the couples to test an embryo prior to the establishment of the pregnancy. So this is after conception, after fertilization has occurred, but it is on embryonic day of life number 3 or on day of life number 5. So we're talking about a much, much earlier stage. We identify the unaffected embryos, and this is what we transfer into the uterus to establish an unaffected pregnancy. The procedure was first introduced in the 90s, and as the genetics counselor said, it's not a new procedure, it's a procedure on which we have experience for a little over 20 years. Definitely, it didn't take off until early 2000, so most of the cases have occurred after that time. So when we do pre-implantation genetic diagnosis, as I said, we have 2 ways of doing it. We're either going to do it on an early embryo on day 3, or we're going to do it on embryonic day of life number 5. If it is day 3, we can remove 1, maximum 2 cells from the embryo. If it is day 5, we can actually remove a few cells, usually 5 to 10. We will subsequently send these cells for analysis, and at the end, we will get results that will tell us which embryos are affected and which embryos are unaffected. So what we're going to replace back into the uterus to establish the pregnancy will be the unaffected embryos. As the genetics counselor said, any family affected by NF, where a partner has NF, has a 50% chance of having an affected child. The same thing will happen to our embryos. We're going to have a few embryos, hopefully 10, 12, 15. Most hopefully, there will be some normal ones. We expect them to be 50-50, but again, when you're talking about 10 embryos, 50-50 is not always the case. So what we need to do, how do we do IVF, how do we do PGD? We start with the basics. We need an egg and we need a sperm. We need to put the egg and the sperm together. And as you can see, this baby is doing a pretty good job at doing that, right? So what ends up happening is we use a first step, which is called ovulation induction. The reason we use ovulation induction is because normally a woman will produce 1 egg per cycle. And we don't want to do PGD on 1 egg, 1 embryo. We need many eggs. So we use this first step to stimulate the ovaries to make as many eggs as the patient can safely make. We will then collect the eggs, and I will show you how we do that. We fertilize them with the partner sperm. We culture the embryos. We grow them to day 3 or day 5. And then we remove the few cells that we talked about. We send the cells for analysis. We decide which embryos are normal, and what we transfer back into the uterus are basically the unaffected embryos. So the ovulation induction step is a step that usually will last for approximately 10 days. People will use hormonal injections. They will give themselves these injections every day. We're going to monitor them very carefully with ultrasounds and blood tests to see multiple follicles grow there. And when they reach a point that we think those eggs will be mature, we will move to the next step, which is the collection of the eggs. In order to collect the eggs, to do this procedure called Oocyte Retrieval, we will put the patient to sleep. We use light anesthesia, IV sedation. It's a quick procedure. It lasts less than 20-30 minutes. We use an ultrasound probe vaginally, and we basically can see everything on the ultrasound. We have a needle attached to this probe that will go into each one of these follicles. It will aspirate the fluid, and with the fluid, we're going to get the eggs. The eggs will then be transported to the laboratory, where we're going to fertilize them with the sperm. So when you look at fertilization up closely, that's what it looks like. Normally, there'll be many spermatozoa outside of the egg, and only one of them will actually fertilize the egg. When we do IVF and PGD, we actually choose which sperm will fertilize the egg. We need 1 sperm, 1 egg. We don't want to have anything else outside of the egg. So we use this procedure that is called ICSI, intracytoplasmic sperm injection. Basically what it means is that we inject the sperm into the egg. We create the embryos, and you can see right here, this is the first on the left-hand side is an embryo on embryonic day of life number 1. You can see the genetic material from both the mother and the father are basically making the first cell of that human embryo. Over a period of 2 days, the embryo will have 2 to 4 cells. On day 3, it's going to have 6 to 8 cells. You can see you can see the cells very clearly there. And if you allow this embryo to grow to day 5, you're actually going to have an embryo that has a few hundred cells. So you can remove the cell either at this stage on day 3 or at this stage on day 5. It can be either or, and we decide based on the family situation. So when we do the biopsy on day 3, you can see that we basically make a little opening on the outside of the embryo, the shell that keeps the embryo intact. We use a very small, very thin instrument, a pipette, to detach one of the cells. We take this cell away from the embryo to send it for genetic analysis, and the rest of the embryo will return into the culture, where it will stay for another 2 days to await the results of the genetic analysis. When we do the biopsy on day 5, we do exactly the same thing. We make the little opening on the outside of the embryo. The embryo on its own will hatch within 2 days, and those cells that are first hatching out of the embryo are the cells we're going to remove to send for genetic analysis. So either or can be the procedure that we will follow for a particular couple. Subsequently, and you don't need to look at all these details, what we're looking for is in this culture of embryos, we want to know which ones are the affected and which ones are the unaffected. So specific laboratories, specialized laboratories will use complex technologies to basically read that cell we send to them and tell us which are the embryos that are suitable for transfer. The embryo transfer is actually a very simple procedure. All you do is you load the embryos in a very thin catheter, in a very fine tube, and you put that tube inside the uterus. At the same time, you have the ultrasound from above that helps you know where you are. And you basically just push the bubble that contains the embryos. So you're replacing the embryos back into the uterus in a friendly environment, which is ready to accept these embryos, and hopefully the pregnancy will be established. You can actually see some pictures right here. You can see the ultrasound helps us see exactly where those embryos will land. So we know exactly that they're placed in a good, favorable position. Subsequently, the next step is for those embryos to implant. So this embryo now, it's going to dig into the wall of the uterus. It's going to find a place that is going to be, that is going to allow the embryo to nourish and grow, right? So we will establish the early pregnancy. We're going to make sure, with the use of the ultrasound, that the first few weeks of pregnancy are progressing well. And at that point, if the embryo is developing well and there is a heartbeat, we're going to send our patient to obstetrics. Hopefully the pregnancy past this point will progress just like every other pregnancy that was conceived spontaneously. So usually, at this point, the patients ask me the same questions. What are the chances that this is going to work? How much is this going to cost me? What are the chances my baby is going to be healthy? What are the chances we might make a mistake and this baby might still be affected despite the fact we took all these extra steps? Can mistakes happen, right? We're taking all these steps to prevent this, but is technology perfect? As you heard today, technology is pretty good, but not perfect. So mistakes can happen, but they are very, very rare, fortunately. We take every step we can to decrease that risk. Most of the time, if a mistake will ever happen, it will be mostly because of human error. People just went home and had sex. Doesn't matter what we did in the lab, they can still conceive on their own, right? Or people transfer the wrong embryo Fortunately, that is extremely rare. At every step of the way, we have 2 people identifying everything. So the chances that an error will occur is probably well below 1 in 1,000, probably even less than that. However, there are technical limitations as well, right? So it could be that we took every step very carefully, but you know what? Our test had limitations, so there is a very, very small chance there could be misdiagnosis. And because of that reason, we will still advise people to undergo an amnio or CVS to be 100% sure. Of course, if you don't undergo PGD, the chances that you will have an abnormal embryo at this point is 50%. If you undergo PGD, the chances that you will have a bad result here are very close to less than 1%. How about the babies born from PGD, right? As we said, this procedure has been happening for approximately 15, 20 years. So we don't have any individuals born from PGD that are 60 years old, so we can't predict, long-term outcomes. But as far as it concerns babies that have been born and have reached, 5 years, 10 years of life, we don't have any major concerns when we compare these children to children that are born to in vitro fertilization for other reasons. Of course, as you understand, a good percentage of people will actually have twins because quite often we transfer 2 embryos and not 1 to increase the chances that the couple will conceive. So approximately 1 in 4 couples that undergo IVF and PGD have twins, right? And twins have higher rates of complications. Babies can be born earlier. They might be growth restricted. There are other obstetrical complications associated with that. But in general, babies born from IVF and PGD are where they are expected to be. They have normal birth weight, normal length at birth, and that we know of, they don't really have more birth defects than babies born to IVF and ICSI. At this point, I would like to tell you that everybody that is trying to have a baby has a 2 to 3% chance of having a baby that has a birth defect. And if that couple is a couple that is undergoing IVF, this risk is slightly higher, is 3 to 4%. What we tell people that undergo IVF and ICSI is that their risk of having a baby that has a birth defect is 4 to 6%. Many times, we don't attribute this to the procedure itself. Many times that's a consequence of whatever factor brought the couple there at the first place. The reason I have this up here is to remind all of us to keep in mind that there are good times to do this and bad times to do this. As women get older, their ability to get pregnant and have a healthy live birth will decrease no matter what their history was before, whether they have an F or don't have an F. Women after the age of 38 will experience, for the most part, difficulties conceiving. So when we counsel patients with an F, we want to keep in mind that we want to do this earlier rather than later. So what are the chances people will get pregnant? As you can see here, age plays a huge role. These are people that just had IVF, not people that had IVF and PGD. And this is based on thousands of cycles. So women that are under the age of 35 that undergo 1 IVF cycle have a 1 in 2 chances of going home with a baby in 1 cycle. When women get older, that chance drops dramatically. It becomes 1 in 6, 1 in 8. That doesn't make patients happy. So what are the chances that if we do IVF and PGD, people will go home with a baby? Quite often, people think that if they undergo IVF and PGD, since they're not infertile, and they are not infertile, they're just doing it because they have an F, that they will have a higher chance than the 50%. This is not true, because quite often, we don't choose the embryo that has the highest chance of getting that couple pregnant. We choose the embryo that does not carry an F. So on average, we expect that 1 in 3 couples that will undergo IVF and PGD will have a live birth in one cycle. There is one study that was spearheaded by Dr. Plotkin that looked at our experience in the United States and found exactly that approximately here it was 1 in 5 couples, the main reason being the fact that we didn't really have good follow-up on most patients that underwent IVF and PGD. But one thing I just wanted to point out to you is that not every embryo is destined to give rise to a live birth. Not every embryo will give us a reading, so we want to get as many as we can so that we can have a successful outcome from this procedure. So in conclusion, for couples that are at risk of having a baby with a genetic defect, IVF and PGD represents a major scientific advance. Before people undergo IVF and PGD, they need to undergo a few steps. Usually I tell people when they come to the office that they need to give themselves approximately 4 to 6 months. So the first thing we need to do is we need to send them for genetic counseling. They need to understand the limitations, the risks, the benefits, and how this whole procedure works. Quite often we have to actually do the testing to identify the mutation. And of course we need to test couples' fertility and get their bodies ready for pregnancy. But once we do that, as I said to you, we feel pretty comfortable that the chances that they will have an unaffected child and the chances that their child will otherwise be healthy, we feel very comfortable that this is actually comparable to anybody else that is undergoing IVF and ICSI. So we usually advise them that this is a safe method that will help them avoid the birth of a child that might be affected by NF. At this point, I am open to questions you might have, but I would like to welcome up here Matt, who actually introduced himself to me a little earlier and told me that he and his wife underwent IVF and PGD in Chicago, and they were blessed with 3 unaffected children, so he wanted to take a minute or two and share his experience with you as well. Thank you.
Least romantic way to have a baby ever. There were 6 people in the room when my wife got pregnant and I wasn't one of them. So just be aware of that going into it. We went through a really difficult time emotionally to decide what was the best path for us. So I'll say this was our experience. This is not going to be the same experience for everybody. But I wanted to share what we went through throughout the process of PGD. When I was diagnosed with NF, I was inundated with acronyms. You know, you've got NF, you go learn about it through CTF, and then you have kids with IVF and PGD. And it's a lot to take on. And I've been on your side on the tables where you get the duplex, module, mosaicism, and it's hard to keep processing that. So I wanted to add that and the reason I asked, Dr. Souter was nice enough to let me come up here, is this is a real thing. This isn't Star Trek. You know, it was 10 years ago, somebody was talking about an ABI. I didn't know anything about it, but now I can only hear because of my ABI. A few years after that, we came, and people at the CTF, like Dr. Souter, were talking about PGD. Now we have a 9-year-old kid that struck out in Little League today, a 9-year-old daughter going to Indianapolis for gymnastics state finals. My 6-year-old daughter is learning to play Taylor Swift on an acoustic guitar. And all are negative for NF because of the science and the process of PGD. So I know it's easy when you get inundated with this information, but this is real stuff that we're fortunate to have these brilliant medical professionals focusing on this. And these are real everyday things that are making huge impacts in people's lives. So I just wanted to make you aware that this is a real deal. And I'm glad you guys are here to learn about it and to have an opportunity to speak to scientists, because maybe this doesn't apply directly to you, but if it does, this is just a wonderful opportunity to learn about some life-changing science that's happening right now. So thank you.
So any questions you have about the procedure? Yeah, please.
Thank you. In your presentation, you described the process with day 3, day 5. You make the extraction, and then there's genetic testing that occurs before implantation. We just learned about genetic testing taking 4 to 6 weeks. I'm assuming it's a different process. And if so, why is that process not available to everybody?
You mean why is PGD not available to everybody?
No, the genetic testing of those cells that
Yeah.
is faster than 4 to 6 weeks. Why is it different? And if it is different, is the quality compromised?
The way we do genetic testing in PGD is very different than the way people do genetic testing to identify a mutation. So actually, the couple needs to have the mutation identified before we even talk about PGD. There are a few cases where the mutation cannot be identified, and if the mutation cannot be identified, we cannot do PGD. Once the mutation is identified, we work with a specialized laboratory to create what we call probes. So the probes, if you wish, are spelling checkers. So they are little genetic tools, instruments that will basically bind to the area where the mutation is and will tell us whether the chromosome carries the mutation or not. So we actually use the knowledge that you have already obtained with genetics counseling to build those probes. And there have been situations, especially in patients that have the first mutation in the family, that we have not been able to build probes. It's easier to build probes when it's a familial case. So when we do a day 3 biopsy, we will usually get the results back within 48 hours. So we can still do a fresh embryo transfer. We can put the embryo back into the uterus at that cycle. If we do a day 5 biopsy, by the time we get the results back, it's too late to do the transfer. So we actually have to freeze all the embryos in that cycle, and the patient will return in a future cycle to have those embryos replaced. Okay?
First of all, I love your candor, so thank you. I have 2 quick questions. The first one would be, what are the benefits or risks of doing the extraction at day 3 versus day 5? The second one is, and given what you just explained, maybe the answer is no, but can parents who are not carriers of NF but already have a child with NF go through this process to see if their next child is at risk for having NF?
Yeah, so your first question was, how do we decide on day 3 versus day 5, right? And that's a very good question. So day 3 was more the mainstream technology for quite a while, and day 5 is emerging more as a technology recently. There are situations where we have to check for more than one thing. I wish every patient that would come in only had NF. There are situations that, one partner carries NF, the other partner carries something else, or the couple, just because they're approaching 40, they're very worried about everyday things, i.e., can I have a baby that has Down syndrome? Doesn't have NF, but has Down syndrome. So in situations where we have to test for more than one thing, we definitely prefer day 5 because we have more genetic material. The biggest limitation of day 3 is that you remove one cell, and that limits your ability to have a test that can be accurate in a few situations. It's safer to remove 5 to 10 cells on day 5 because each cell will confirm the diagnosis of the other cell. However, like I said, if you look at it from the cost point of view or from the time invested by the patient, this patient that undergoes a day 5 will have to come back in the future and have a transfer. So that's extra money and extra time invested. But we discuss this with the families. We look at the individual mutation, at what we have, and we make a decision. Your second question, I'm sorry, what was it? I forgot already. Yeah. for parents that who do not have NF and they just have one child that had the NF, so it's an isolated case, we probably would not advise them to undergo IVF PGD. We probably would not advise them to undergo an amnio or CVS for that purpose either, because the risk will be much, much lower, and in this case, the risks wouldn't outweigh the benefits.
Thank you.
And just to kind of piggyback off of her last question, what if the parent was never diagnosed with NF, but may have the genetic makeup, but not have the clinical diagnosis? Could you, like she was saying, because they told us, when we had our second child, that our second child probably would not have neurofibromatosis. However, after attending this conference, now I'm looking at my second child, and I'm seeing the clinical, not the clinical, but possibly the genetic side of it, because she's displaying other characteristics like the learning disability, the speech delays, the bone deformities. And so, it just is tough because 10 years ago this was not available to us, and my kids are about 9.5 years apart. And so I'm just, wondering,
Yes, I will.
what could have possibly been done.
First of all, I would start by saying that any parent that has their child diagnosed with NF is traumatized enough to think that every child born after that has NF. What you say is something that we've heard quite a few patients say, and it's not just with NF, it's with any disease. If the child is diagnosed with leukemia, the mother is going to be fearful that her next child will also have leukemia. So you're bringing up a very important point that it's the unexpected and the trauma that comes with it, and how do we counsel those patients, and what are the limitations? We do have cases that the parents have mosaicism, right? And in those situations, it's hard to counsel the couples because you don't know if their ovaries or testicles are involved in the mosaicism. So if the ovaries are not part of the affected tissue, the risk is probably very small. But if the ovaries are part of that, then the risk of having a baby with an F will be 50%. So there have been situations where certain tissues of the body have been tested and the diagnosis has been made, and we can use that to do IVF PGD. And there are situations where we were not able to identify the mutation again, and we couldn't do PGD. So those are harder cases to counsel. I recently had a case like this. She eventually conceived on her own, and she underwent an amnio. And fortunately, her baby is unaffected. But she will have to do the same thing for the next pregnancy and the pregnancy after that, because there's no way for us to know whether her ovaries are affected or not. So there are limitations, definitely.